for you too at the moment?
100?
I don't know if I trust it, but pretty happy. Happy for me to begin. Big incision all the way through the skin. All the way. Be even more greedy. Change over to our nuts and bolts.
Once his blood pressure comes, we'll drop that down too.
So just part that away.
We can just drop down here. Anesthetic start time was 3:21. And surgery start time was 3:41.
Pretty lucky there's no massive vessels here, which is good.
I'm skipping all of that. His blood pressure is pretty low.
So that's going to be the point. I actually can't go much further than that.
Bolus.
Just going to bleed a bit. Try to stop it. Change our blade. Pick up, stab incision in. Good. Stem down mets and bombs. Being worried that I don't enter the chest. Like I should be able to go up to there. Cool. Open it up. You may have some blood pooling. That's not what I want to see. Put some lap sponges out. Means that there's trauma here that we didn't know about. Because we have a big incision, we're not going to use any small swabs in the abdomen. So if you see me grab a small swab, tell me not to put it in the abdomen. We're only going to use big ones. Just grab a bit of that up. So try not to make a mess. Put in our little balfours. Trying not to trap anything. May actually need some bigger ones.
Bigger balfours?
Maybe. Yeah, I'll have the bigger ones, Ash. I think they go from this comically small one to a much bigger one. Now that we've entered the abdomen, can you just make sure that we are breathing to a degree? So we'll go 4 breaths a minute as a bare minimum, and we are now inflating the lungs.
Getting some good breaths in.
Good.
That's a drastic size difference.
Let's see. So no matter what, we now need to breathe for the patient, and I'll get Ash to show you. We're going to use the different breathing bag down.
That bag is so that's exactly what you're doing out there.
Beautiful work. Sorry about that. I'll get you just to retract that. We'll hop in one of these. And I'll get you to retract that. We're just trying to make sure we don't get too much things caught in there. Very good. Happy with that. So we can see our hernia. So what we'll do, let's see if we can get it back to where we should. So we're just going to pull out our abdominal contents. So we've absolutely probably traumatized our liver, so I want to be really delicate. Rather not rupture more that's already been ruptured. Can't really repair anything. That's probably most likely where the bleeding's going to come from. Hold that up there. It's going to be really delicate with this liver. I reckon it's going to be traumatized. That's probably what's been bleeding. Just try and grab that liver lobe, just like that. Pull it back through. Still got one more liver lobe up there. Alright. So that bloody fluid could be, most likely it's from some trauma. So now that we've got everything back where it should be, we need to have a look at everything. If you want to just put your 2 fingers here just behind that liver, you can just act as a bit of a stop guard. Big liver. Probably didn't like where it was. Okie dokie. Have a look at our liver, see if there's any other bits that are overtly traumatized. There's obviously this bit here, but as far as bleeding goes, that looks pretty good. It's the gallbladder. I don't think there's any massive bleeders. Let's have a look down here at this lobe. That looks pretty good. Okay, look. We'll go on, we'll have a look at our stomach. Stomach looks pretty good. Trace our stomach. Duodenum, carefully. Got the pancreas there. Pretty good. Take these ones out a bit. Tracing our intestines. If you see any massive squirting bits of blood, yell out to me. Cats are pretty good when it comes to clotting. I guess what we don't want is to have something that's just rapidly oozing blood. So intestines to our cecum, a decent sized lymph nodes. Farm cat. Going on to the colon. So that all looks pretty good. Got our spleen. Doesn't look like it's bleeding at all. Kidneys. They look fine. Other kidney looks fine. Can't see any massive. I reckon all the bleeding and oozing is going to be from the liver. The question being is, I don't think it's at the degree where I need to do anything. I'll just sop up a bit more of this blood. So we'll do a good job. Let's remove all the blood and then we'll see. We'll see how much kind of just appears out of nowhere. That's good. There's a fair bit of it in the lung cavity. Sit in there. And again, whatever's traumatized in there, I can't really do anything about. Not doing any thoracic surgery. I might just try to sop up a bit of that blood in the lungs. Delicately. Cool. Nice and gentle. That's the majority of the blood gone. The majority of the blood gone. So we can now, hopefully, we won't have any more kind of accumulate, and if no more accumulates, at least it's probably from the oozing and bleeding that's already been here. So now we need to see if we can suture. So I'll get to let that go. So the next step is going to be trying to suture our diaphragm. What's involved is you're going to put 2 fingers, get a little pressure there, 2 fingers here, and you're just going to gently lift up, and I'm going to work in the crevice essentially, and we'll see how we go. We're going to use PDS because we want it to last there a while. We'll use 2O, which is probably appropriate for this size. And we're just going to probably start down low and come up. It doesn't look like the easiest one to suture. Like, it's fairly big, to be honest. Nice. So we'll start.
My hand going to be in the way there.
That's pretty good. I think we're going to start down low. Just going to be cognizant. Like, it's ripped right at the kind of liver edge. And I'm just trying to think of where these vessels are. Yeah, so I think you're holding that perfectly. I just want to have a feel. As to what's what. So that's going to be, possibly the caudal vena cava. Like, there's a massive vessel there. I reckon that's the esophagus in there. Ash, you wouldn't mind directing the light more down and in?
Do that.
Yeah, that's good. There you go. Also see if you can maybe get a better shot on that.
Oh, the camera.
Yeah. I reckon that's a vessel right there. Just want to feel it for a second. I actually want to pass the tube as well. I just want to identify what the esophagus is. Yeah, same deal.
Esophageal stethoscope?
Yeah, that'll do. It's not an area that I'm frequently in. I'll get you to let that stuff go there. It's really... And that goes to there. So like that. Yeah, I reckon. So maybe I'll start repairing what I know I can repair. So let's repair that axial tear first. Yeah, 1 sec, Ash. Yeah, tell me when you think you've gone in enough to go into the stomach. I'll have a feel as you come. Okay, can you go back a moment?
Hey.
Can you go back? Yeah.
More?
Yeah. So I can feel you, you're nowhere near me. Right there. Can you go back more? Back more. Back more.
That's out.
That's right, I'm feeling a rib. Alright, we'll come in again. How many times is it like that?
That's why I'm pretty sure it's past that point.
Keep going. Alright, I feel you. So you're a lot more ventral and nowhere near where I'm suturing. Go in and just a smidge more. Yeah, so you're very much down and away. We're going to repair what we can do. So often when you're not sure in surgery you do what you know you can do, and then hopefully by the time you finish it you're more confident to do another thing. So this is our axial tear from there to there. Start there. Start there. Simple. We will prepare this bit first. Single continuous coming up.
Is there an hernia?
Yeah, it's a bad one, Jeremy.
Just sew it up. Stop talking. Why did you say my name? Stop saying my name.
I think it's exactly what I said everyone's saying now.
That was good.
Get it over there, fine. Lucy, Travis, and Lee can do that.
Like animal ones or people ones?
That one. Annoying suture material, the memories doesn't want to go where I want it to. Awesome. Looks like we're pretty much at the end of that one.
Like
And do it nice and tight. That's right, let me help you out. Good. Good work. Alright, so that's the easy bit done. So that's an axial tear. So it's going from the centre out. I think that's what they're called. Circumferentials when they're going around the circumference. I don't know what you would describe this other tear as, bloody literally at the kind of hilus, or like it's kind of where you do not want to suture. Normally most diaphragmatic hernias are like this. It's either an axial tear or a circumferential tear. Alright, so that's the simple bit. Now let's re-loop. So I reckon this is very much ripped off. What would be the area? Kind of like that. That seems to come together pretty easy. I'm looking to make sure where there's going to be less tension. That looks pretty much like less tension. It all comes across pretty easy. A little bit of tension there. So it's about defining what I feel like I can suture through on this side. Yeah, I'm not.
What to work with.
Well, to be honest, I'm not confident about what's vessel and what's not. It may be that I just have to see how I go. Let's see what's through. So that right there is 100% throbbing. So that right there is a vessel. That right there is a vessel. I reckon I can skirt. It's going to be very, anyway. So we need to see how we go. I may hit some vessels here. It may bleed. The trick here, I reckon, is going to be trying to maintain tension on the suture material.
Yep.
Let's start off. Start off on some easy tissue, maybe. Just going to do one suture in the middle. Oh, good. That came out there. I just want to see how much tension there is. See, that's starting to try to pull through there. I'll get you to release everything, I just want to see. I reckon there's too much tension there. I reckon that's about right. Right. I'll get you to retract that back again. goal is we want to do this in one pass. So it'll take a bit of time, but with every one we want to be happy with the amount of tissue that we're obtaining, which normally would be really easy. Less so with a big old vessel. See, there we go. What would be good, Ash? Can I have my loops?
Which ones?
2.5, please. At the end of the day, I am just hoping for the best. Maybe if I can get a bit more visualization, maybe that would be of benefit. So 1 moment. You wouldn't mind taping my mask?
Yeah, I'll do that first.
Thank you. Thank you.
Alright, what's in there?
Yep. Let's go table up.
Is it in?
The issue is, I can just see that it's on a tear. I think it's doing that already doesn't bode well. That would make a lot of sense. May change tact here a bit. We've done simple continuous down there. Normally I'd always do these with continuous, but maybe I do interrupteds. As we can kind of predict that some of these may break down.
Yeah, right.
I think that's not a bad idea. See if there's like another bit of tissue I can attach to, but I truly think that is it.
Yeah.
What we'll do, we're going to start to pre-place things. So we'll do, just maybe going to waste a bit more suture, but
You need more.
I think I got another 2 PDS. What we'll do that. We grab our suture scissors. Keep disappearing. Try not to make life too hard on us when it comes to the suture length, but no matter what, I'll probably regret it. So we just do that, and then we move on to the next one. That way I won't close it. I want to be able to see what I'm doing. That. Next one. Every time I go through this, I'm just expecting it to start to bleed. Do that. Makes life easier for you. Actually, you can twist that. It would jumble all around, but I don't know if that makes life easy. Alright, we'll go again. Really great thing for you guys to do some research on tonight. So one, what is the name of it where the hernia is right in the center? I think it's a hilus. The axial, circumferential, and hilar. And 2, what do you do? Yeah, another great thing to figure out. What's up, Lewis?
Pretty sure we can count this one.
Just whatever you want more. No, I'm not doing this.
Say again? Probably just leave it out there on the bench, Lewis.
Yeah. I just want to see.
Yes, I've watched the tissue. Normally with these, yeah, in general, I'm really greedy. You're trying to grab a big bite because you know that tear through. Not so much at the moment. That's already weak. A little bit greedy. Actually, some fluid before we wet down these intestines. If we have a bowl, we'll grab a bowl, we'll grab well, he's got this really weak tissue, so I am literally trying to skirt this vessel a bit and then grab this tissue. So I just know that at some stage I'll go through it. I wonder what will happen when I do. Like whether or not it will be just bleeding around a hole manageable, or whether it will be like out of control bleeding, like when I hit like a massive heart vessel, where it's essentially game over. Oh gosh. Do you mind bringing that bin just a little bit closer, please?
Do you want to go on the end of it?
Nah. Thank you. Just give these things a little bit of love. Back them back. A little bit more happier. Some coverage. Good. Alright, we'll continue on. So we've done a lot, we're nearly there. Running out of.
She's still in.
Yes.
Without it.
I'm running out of clamps, annoyingly. What else do I got? Soft pallet clamp and these Statinskis. Oh dear. Wow. Do that. Like I think I am now literally grabbing what I'll define as very weak tissue. But then again, I guess that's maybe what it naturally is.
Yeah, it's just kind of
Yeah. Got that big old. Ash, can I have another 2-0, please? Can I have another Ash? Can I have another 2-0, please?
PDS?
Yes.
PDS?
Yes, please. Because, you know, the tissue is,
Yeah, let's just.
it is normally this thin fibre up here.
Yeah.
Can I have 4 more clamps, please?
Tower clamps or hemostats?
Hemostats, please, you're right.
Little ones?
Yep. Sure, vacuuming would be good for the video. Yeah, well. If you wouldn't mind closing that door, please. I'll get you just to hold on breathing for just one moment. Alright. We're now going to go through, tie them all up. So I've done 2 things to try and maximise our chances. I have doing simple interrupted, normally wouldn't do it, but I guess if one breaks down, at least the other ones are there to hold it. Also, I'm trying to throw these sutures pretty close together so that there's maybe less strain on each little segment. There's two outcomes here. I think it's not too hard to achieve an outcome where the cat lives. But what would be an ideal outcome is if it lives and it has a perfect diaphragm where nothing goes in the chest cavity. So that's what we're aiming for. Hopefully we can get it. By all means, if you want to start up just breathing again. Very good. Cool. Next one, in line. Not you. You. Good job. That one, nice. Next one. I'm a lot happier with these ones at the top. They actually turned out to be far better than the ones in this mid region, I reckon. These seem to be the tissue is holding really well. There we go. do you think's next?
I think it's Alice.
Nice. I think for these ones, I just got to be a little bit more gentler. They will just rip through. That one maybe? Oh. Oh. Maybe
It's quite nice. Yeah, that
that
one
one.
would be better.
Yeah, if you wouldn't mind just lifting a little bit more, that's perfect. Absolutely perfect. Good. That one. Nice.
Are you good with these guys too?
I think I am. Thank you for today, Ash.
I just need to go pick the kids off.
That's fair. Tomorrow should be interesting.
Anyway.
Yeah. How are you feeling? All good? Anesthesia
Yeah.
wise?
We're going really well.
That's good.
Blood pressure's been a little bit up and down, mostly up.
It's better. No, thank you, Ash. So far, I would say that I'm actually quite happy with how this is coming together.
Yeah.
I'm doing a very meticulous job, so if it does break down, I'll be disappointed. Got the diagnostic right?
He's scrub it down further enough if when you get to that. If you think it's it, if you slip.
I appreciate it.
He's kind of at his maximum bowels, isn't it? Anyway.
We should be, I think we're zooming towards the finish line now, which is good.
Yeah.
That one's next.
It's not hissing in the air anymore. That's good.
What's up, guys? this stage, what are we going to do? Seamus will often, before you do the last closure, you'll inflate the lungs to maximum to push the air out. Do you want to, you wouldn't mind just inflating the lungs to maximum and just holding, inflate the lungs and just hold it? That's not going to work anyway. Don't worry about it. I think I'll just decompress it afterwards. That way. You wouldn't mind just pushing that somehow out of the way. Yeah, perfect. Starting to work in a cavity now, starting to get harder.
Yeah. At least the liver isn't going anywhere.
That made my life harder. How do I do this? And that there. And that there. Grab a small hemostat. See if I can manage.
Do you want to be a man?
Great question.
Three bottles of drink.
What's our total volume that we've shoved in? Mils of fluid.
132.
Cool.
So it's at 44 mils per bottle, so 3 bottles is always 4
Yeah, like Diaphragmatic would be ideal. Do you want to? I can go through it with Steph if you want to just grab Steph and direct her my way.
Yeah. Well, I can get it sorted and she can connect it.
Yep. Oh, where's that one there? There. One more to go. It's amazing how much more difficult it has suddenly gotten.
Tucked right in.
Yeah, we are tucked in.
Yeah. Sorry, my retracting is getting bad because my hands are tied.
No, you've done a great job. I'll remove that. You only have literally one more to go. It's that one there. I think your job is a lot harder than mine, just holding it still. See how we go. Okay, so that hemostat again. Gone through there a bit for some reason, that's fine. Okay. So we'll just let everything go. I've learned that this is the hardest one I've ever done. I much prefer the circumferential and the axial ones. I'm happy that, bleeding wise, none. So at least in this area, I don't think we have to worry about hemorrhage. I think my perspective is, I'm very happy to, much more blasé, but much more muscly tissue there. And we have really gone to town. I'm very happy with the top bit. The bottom bit was a bit more dicier, if I'm being honest. My simple continuous. And I see a little bit, just wanting to tear a little bit there, but I think this is the leaving well enough alone type scenario where I think we've had a very good attempt at repairing that. I'd love to know how it works, to be honest. It'd be nice if one day we can. We never will. There's a part of me that wants to do more. I'm just going to put one swab, make sure it comes back out the abdomen. Do you want to retract that just nice and gently? Yeah, I should be happy with that. I'll leave well enough alone. Alright, let's start to close up. Everything's out, we've left no swabs in the abdomen. You're just going to continue to breathe no matter what, and then when I'm finished this, I'll do a thoracentesis and take the rest of the air out. Yeah. Can I have another of the 2.0 pink suture material, 2.0 PDS suture materials? Do you have any questions, Indy?
Just the foreign body, like having the knots there facing the liver, are you expecting that to
100%.
rub up and cause issues?
100%. No.
Can't really do anything else though.
I think, so we normally do them simple continuous, and the benefit there is you don't have that. Like I've made a lot of annoying knots which would probably elevate the ALT and all that stuff, but in the grand scheme of things, it's not the end of the world. You know, having shorter acting suture material, I want to have something that will be there for a bit. I just don't want it to break down too quickly. And yes, the liver will be a bit annoyed, but eventually, what's the breakdown for PDS? It's all gone in 6 months. Just one more PDS, please. Yeah. Same deal here. I normally just use a glycinate suture. Because we've got such a big incision, I will actually use a PDS. It'll last a bit longer. Yeah. I normally don't use PDS for much. For some reason I'm using it a lot now.
See you tomorrow.